Here's Ken Wildrick.
Well, you all know that I'm a doctor, and I had practice in pulmonary and critical care medicine for 30 years or so. And then I was in an administrative position heading medical education for our residencies and our medical students from Autonomy and what's now Drexel, and was vice president of medical affairs. So I dealt with a lot of issues of planning, but also issues of discipline and all sorts of things that I'm happy to have put aside. But I got into a lot of issues regarding medical ethics and some of the tough decisions that people have to make regarding severe illnesses and end-of-life issues and the like. So I thought I would just present a particular case today. That is one that I saw, and then you can work with me to see what you think, how we would handle this thing. So here's the case. This is a 30-year-old man, Frederick. He's a prominent business executive. He has 2 young children and a young wife. They have substantial debts, including a mortgage of $200,000. He's in a coma following a fall from a ladder, and he's been in the hospital on a respirator for now 6 months. He's lost a lot of weight, and he's just the shadow of his former self. He makes no response to his external environment, and the doctors have said that he has no reasonable chance to do so in the future. His injury was devastating. At the same time, the colleagues decided, the medical colleagues, that he was not brain dead according to well-established medical criteria. Now the family is trying to decide about whether to stop his respirator and or his feeding tube. They've also asked whether it's appropriate to continue to treat each and every infection. Should his current treatment be considered heroic? Is it time to let go? So here are the things we're going to consider when we try to work through this case. First thing we'll talk about that's important is, what does the term heroic treatment actually mean? And does it apply to Frederick? What is brain death? I told you that he was said not to be brain dead, so let's decide what that actually is. Is treating him a futile thing to do? What kinds of guidelines or principles can his family use in helping to determine his future care? Can his treatment be ethically withdrawn if he's not brain dead? Remember that they were wondering whether to withdraw his feeding tube and his respirator. What do we do when the family members don't agree with the patient or with each other? That unfortunately happens all too often. Well, let's first deal with what it means to be heroic treatment, since that comes up still a lot, though less than it used to. And if you just look at these pictures, they're supposed to key you into thinking that heroic depends on where. Is it in an underdeveloped country? Is it in a high-class dentist's office or operating room? Well, is it a matter of the time? What was heroic many years ago is not heroic today, and will be even less heroic in the future. So the term heroic is kind of a difficult one to deal with. It also depends on the nature of the illness. So if it were a young adult that had an acute disease, you pretty much throw the sink at him, do everything you could. Nothing almost would be too heroic to try to save a young person in an acute circumstance. That's one end of the spectrum. On the other hand, it might be considered heroic if you want to continue things for somebody who's called brain dead, or if it's something in between, or if there are other considerations relating to the chronicity and severity of the illness, where you might not want to consider, you would consider one thing heroic and maybe not another. And it also depends on the individual's own experiences. A person may think getting a vaccine is a heroic thing in today's situation, for example, whereas others wouldn't. So there are lots of things that depend on what that actually means. Well, since the idea of heroic is so difficult to define, we've really settled nowadays into what we call a decision between the burden and the benefit of a particular treatment. So, for example, that healthy adult, the burden of mechanical ventilation or surgeries or other aggressive treatments would outweigh the burden of care in most of these kinds of cases, at least for an initial period, so that you could see whether the patient can recover. So there, the burden would seem to the benefit would seem to outweigh the burden. On the other hand, what about somebody who has been declared brain dead? Here are some examples of brain scans. That is one of the ways in which brain death is determined. And brain death is defined as a complete cessation of all brain function. Complete cessation of all brain function. Now, that doesn't mean that the peripheral reflexes may not remain intact. And one of the challenges in a hospital setting is that family will say, oh, he just moved his foot or his finger or something, when there are such things that are meaningful, but sometimes these are reflex movements, and unfortunately leads a family to believe that the patient is alive still when it's really only a reflex action. So when somebody's declared brain dead, we consider them in fact to be medically dead. There's no benefit in that case to the patient for continued therapy, but there is a continued and substantial burden primarily for the family, isn't there? So therefore, ongoing treatments are not going to be indicated except for a short period to allow for family visits and hopefully for the opportunity of tissue donation. And there are many ways to verify brain death. And unfortunately, once in a while, there are mistakes made on that where they haven't used the appropriate methods. But when you're using appropriate methods, it's pretty much a certain thing. I don't think I would be concerned about the right diagnostics coming to that conclusion. You can see in this particular set of scans on the center that there's no activity being picked up there by the scan material at all. And that's one of the good examples of a technique used to absolutely verify the brain death. Now, hopefully, when brain death occurs, it's important because we want to make an opportunity for there to be organ donation. We can keep the peripheral body functioning for a substantial time, but when you're brain dead, they will ultimately all fail. It's just going to be a matter of time. But if we're sustaining somebody for a while, till we can get to harvest the tissues, that can be a great advantage, obviously. And this all revolves around the understanding that medical death or brain death dies on a different time schedule than do the other tissues. Body tissues die at different rates. The brain tissue is the most susceptible to poor circulation and oxygenation. Heart and kidney tissues are more vulnerable than legs, skin, and bone. So they die more slowly, and often skin and bone can be donated for burn patients, for example, even when the heart and kidneys can't be salvaged. So there's think of the fact that these tissues undergo cellular death at various rates, and that allows for that wonderful opportunity to donate organs or tissues. Now, in our case here, Frederick was neither brain dead, and he's not really a healthy adult either with an acute illness. So where do we go from here? The next question would be, are his treatments futile? Well, that depends. And there are two ways we think of a futility in terms of medical treatment. One is what we call physiological futility, and the other is non-physiological. So physiological is where the treatment doesn't have a specific medical effectiveness. And in that case, it's not indicated. For example, if you wouldn't give somebody antibiotics if there was no infection, because it wouldn't have any positive effect. You wouldn't perform cardiopulmonary resuscitation, CPR, for someone who was in irreversible shock, where the final cardiac arrest is a result of the failure of all the other effective therapies to reverse the shock. In that case, doing CPR wouldn't be effective. That's why we have no CPR orders for those very terminal situations when the rest of the circulation has failed. And that brings up this question of what does it mean when somebody says, I want everything done? Well, I think I'm probably correct that most people want everything done that could make a difference. And it doesn't apply to a treatment simply because it's available if it won't even be effective. So when somebody says, I want everything, you need to kind of take that into consideration of what's the circumstance and what is everything that can really make a difference. Now, in Frederick's case, antibiotics could be effective. If you got an infection, they wondered, should they keep treating every infection? And medically speaking, if you give them antibiotics, it could be effective. And tube feedings, well, yes, they can help sustain his nutritional status. So it does have a physiologic effect. So we have to say in Frederick's case, his treatments weren't medically futile. So then what about non-physiological futility? Well, that's where treatment is considered from a patient's perspective, that it lacks any value to the patient, or it fails to meet the patient's goals. So for example, in this case, Frederick and his family might say that the burden of prolonging his survival in his current condition with his feeding tubes and respirator and current infections, maybe skin sores, that maybe the burden of all of those things is not worth the benefit of his surviving in that state for an unknown period of time. So Frederick's situation could represent non-physiological futility, depending on the patient's and the family's individual wishes and their goals. So it does all depend on the person's and family's goals, their values, and what they anticipate to look forward to. Now, I say there's a big caution to this whole issue, and making sure you recognize individual patients and families' values. I had a patient who had ALS, and by the way, in the Express today, there's a big article on Lou Gehrig and ALS. You might be interested to follow up on. I had an ALS patient whose family decided that they absolutely would not give up on everything that could possibly be done for this fellow who lost his ability to communicate, except with his eyes. And they maintained him on home ventilation for, I would say, probably 3 or 4 years. He had multiple hospital admissions for infections and so forth. But for them, it wasn't absolutely medically futile because we could keep him alive medically. And they decided that it wasn't futile for him because they valued that minimal ability to be together that he experienced. I had another person on the absolutely opposite end of things who had a terminal disease. He ended up following CPR on a respirator, was obviously failing fairly quickly, and he wanted to undergo repeated CPR. We were asking him and the family, did they want to have a no CPR order if that came about again, would he want us to continue with that? And he indicated he did want that CPR because he wanted to live long enough into the next month so that his pension benefits would be available to his wife. So there you have a very specific value and goal that that man had. And he did have a couple more CPRs, managed to survive them, and he made it into that next month, after which he said now he didn't want any more. So many patients have longstanding chronic diseases, and they decide the burdens of their care have become greater than the burden of, and the fact of death itself. So that's yet another circumstance where this whole issue of burden versus benefit is so individual, and you have to be so careful to control, to take consideration of those things. Now, suppose you're the surrogate. You're the one that's going to make a decision for a family member who can't give his decision himself. There are a few specific guidelines for that. One of the first of those is the issue of beneficence. That means to be benevolent, to be doing good, or to be kind-hearted. It's the ethical principle that is the most primary, I think, of a surrogate. You're providing benefit for the patient. The goal is to provide benefit beneficently. Another one is what we call substituted judgment. That means that you should be doing what the patient would want based on the patient's values and earlier statements if they're known. Now make a note that the decision does not depend on what the surrogate would want. And this is where living wills and medical durable powers of attorney are so important. Sometimes it's very hard in a circumstance where a tough decision is to be made, where the surrogate actually may disagree with what the patient has said were his or her wishes. But the appropriate ethic is the same, and that is you should do what the patient wanted. You're substituting his judgment for him. You're providing that substituted judgment. And this means for all of us who are still alive and kicking, that we should make sure we discuss our wishes with the person who holds our durable power of attorney, but also with all the relevant family members that we have, so that there's not some bitter disagreement when the decision is made. You can go a long way towards avoiding a real kerfluffle in that circumstance. The next guideline is a best interest judgment. If you don't know what the patient's philosophies are about end-of-life issues, the surrogate has to decide on the basis of what appears to be in the best interest of the patient after balancing the benefits and burdens of care. And that's another tough one, but look out the best interest of the patient as best you can determine it. Now, sometimes you'll have values that will conflict with each other in making decisions using these guidelines. For example, you may have the feeling that the preservation of life is one goal, one value, but the relief of suffering is another value. There are two values that conflict with each other in some cases, and that's a burden versus benefit decision. It could be a matter of something like the care of the patient versus the financial well-being of the family. I've come up with that one with patients too. They'll say, we wanted to save money for our son's college or my grandson's college. How do I balance this out? Well, here the ruling value should be best interest of the patient. Saving money for the grandson's or grandchildren's education should not be the reason to withhold Frederick's treatment if that were to be the case. Then a best interest judgment. Now, there are a group of other things that we also use in making all kinds of judgments as physicians. One of those is this one number, Roman numeral 4 there, justice. And this comes up in hospital situations also. what about the care of the patient versus the utilization of limited community resources? And sometimes doctors are under pressure from hospital administrative people to say, look, we only have so much of this and it's cost that much money. It's not worth that to be spending all that money on this thing or using up all of that resource. But that is not a judgment for a doctor taking care of the patient to make. That is the judgment that has to be made by society and not by the patient. The doctor's role is always to be the advocate for the patient. So in a case where this judgment is to be made, the physician must use the best interest of the patient as the first priority. And society will deal with the equitable distribution of the precious resources. That is not the doctor's role. Now, you'll see other things in here that I put up here just because there are a group of values there that I think you can see can create significant conflicts with each other. Promise keeping versus, trying to, what you're going to tell the patient. Some people don't like to tell the patient everything. They're afraid it will harm their mental health at that point. So you're going to come up against these, I'm sure, in various points in your life with yourselves or with your loved ones or with your good friends. And these are some of the values that you'll look at. And the top of these, the autonomy and so forth, are other issues that are going to be important to you. Now, autonomy, I will highlight specifically because autonomy is a key ethical principle in medical care. And that means that the patient or the surrogate has the absolute right to determine what treatments they will receive. So a patient can make a decision to refuse a treatment, even if it results in death, as long as the decision is informed. And I guess that's the key. An informed decision means that you have received a definite, the risks, the benefits, and the alternatives, and they've been explained to you fully in a way that you can understand it. And then, the chips fall where they do. If the patient decides they want more treatment and it can be effective, like that ALS patient, that's an appropriate decision as long as it's informed. And if a patient decides that it's just too hard to continue, even if it means my death, then that's okay too, as long as it's informed, because there's that autonomy. And you're seeing this coming up now with vaccinations, aren't you? Some people are saying, I just don't want it. And unless it's a requirement of something like a workplace or some other very important circumstance, obviously they don't have to take the vaccine. They still don't have to take it for work either, but they might lose their employment. Now, the other big issue that comes up with this is, and came up with our patient, is how about withdrawing the therapy here for this patient? Turning off the respirator. And ethically speaking, it is not different to withdraw therapy or withdraw any treatment. It's not different from the decision not to begin the treatment. By withdrawing treatment, the patient is actually being restored to his or her former state, and that allows nature to take its course. So it's unfortunately also extremely difficult emotionally. So once the decision is made, it doesn't require, in the circumstance of futility and so forth, the family determines that it's a futile state to them and they don't want to continue the therapy. It can be undertaken for a while and then later withdrawn. When I started practice, we would never withdraw somebody from a respirator once it was started. And this ethical understanding that developed over many years of acute care by various people smarter than me really allowed for a lot better treatment of patients, because you didn't have to decide in the moment of crisis whether the treatment was going to be futile or not, or whether it could be successful or not. You could say, all right, we'll start it for a time. And if we find it's not working, or the burden is too great, it can be withdrawn in a way that the patient does not need to be suffering and pain or be uncomfortable. There are effective treatments that are available to alleviate the discomfort of the withdrawal. And amazingly, I will say, sometimes you withdraw something like a respirator and you find out, by golly, the patient ends up rallying and the next day is breathing on his own. So they didn't put the Godhead in our heads, unfortunately. So these things happen and you're glad when it works out good, that's for sure. Now, what do we do when families disagree? Well, the studies have shown that most disagreements in families occur over a misunderstanding of the facts or the fact that they have different sets of information. Family members may have picked up information from different people at different times and not have ever gotten the whole picture. So the first thing to do is to make sure everybody's dealing with the same facts, get everybody in the same room and talk about it together. The second thing would be to make sure that the patient's wishes are known and are being made known to everyone and that they're being followed. That can alleviate a lot of disputes amongst the family. Is there another morally preferable choice that could apply? Sometimes it's not a choice between A or B because there might be a C or a D. What's the likelihood of the benefit or the burden? It's not enough to say there could be a benefit. Well, how likely is it he's going to benefit? Or number 5, how great is the benefit or the burden? We faced this in the pandemic also, where we knew that the burden of infection with COVID could be death in a large number of people. So even though the likelihood, number 4, might have been low that death would result, the burden could be extraordinarily high. So that affected a lot of people's decisions as to which route they were going to go in their preventive care, for example, or vaccination. Sometimes there's a question about which values are applying. Some people are thinking primarily of pain and somebody are relieving pain, and the others thinking more about some other value. So you have to make sure that you're all dealing with the same values. So what can we all do while we're still alive here again? One is make sure you have both a living will and a durable power of attorney. Some people say that if they have a living will, they feel quite comfortable. They don't want to get a power of attorney. But I can tell you from many experiences that the categories of that are raised in a living will are not black and white. And sometimes you just have to have somebody who can say, I'm going to weigh these things. I know what I'm aiming for because I have a living will, know the overall picture. But when it comes down to an individual decision, you'd sure like to have somebody with that durable power of healthcare attorney. Secondly, make sure you discuss your wishes and preferences with your surrogates. Don't wait until you are in the crisis when you absolutely need to, as we talked about earlier. Communicate your overall values to your potential surrogates. Let them know how you feel about things and how you view life and the world. It's important. And then another thing you can do to really help that surrogate is to assure them that you're confident that they'll make a good decision and you trust them and you're going to be comfortable with that decision. There's a lot of anxiety in most people who haven't had to deal with these decisions. It comes up once or twice maybe in a person's life that they're called upon to make this decision. And they can be very anxious about it and troubled and feel guilty. So help them to feel better about it and give them the confidence to go ahead and make it with your blessing, so to speak. So I just say a couple final thoughts to remember when you think all about this issue. When you're born, you're taking a big chance. There are going to be problems, right? And another one that I think is very important. Death is the natural culmination of life. And in some cases, letting death come may be the most acceptable choice. So I'm going to stop there and see if you have any questions or if you have any discussions you'd like to have. And I'm wondering if did I lose you?
We're here.
We're still here.
Okay. I don't have you on my screen yet, so I had to figure out how to get you back.
You have to go to the top of your screen and close out your screen sharing.
Oh, okay. Thank you. It always pays to have you around, Bill. There we go. Hey, Ray, they're still there. So glad. Any questions or discussions or experiences you've had that you'd like to share with the group? Yeah, go ahead, Skip.
Ken, in your example with Frederick, he was not brain dead. Was he able to communicate at all?
Not in a, he wasn't able to communicate. He was able to move around a little bit, but even barely little of that. But he was not brain dead because there were still some brain functions there that could be identified. So a surrogate had to make the decisions for him. Well, I guess you all know what to do now. Huh? Good.
It was such a timely topic, Ken, and something that we all should be considering.